my name is Yuko Harada from Kawasaki Municipal Ida Hospital in Japan, and we have no COIs. The mortality rate of cancer patients has been decreasing. However, patients often suffer from cardiac disorders due to chemotherapy or other cancer therapies. For example, cancer therapy, it's called cancer therapy-related cardiovascular toxicity, or CVR-CVT. Therefore, the field of cardio-oncology has drawn more attention in recent years. The first European Society of Cardiology guideline on cardio-oncology was established in 2022. For cardiac injury, cardiomyopathy, and heart failure, the descriptive term cancer therapy-related cardiac dysfunction, CTRCD, is recommended. The treatment for CTRCD is standard treatment for heart failure. For example, beta blockers and ACE inhibitors or ARB. Standard treatment of heart failure, such as beta blockers and ACE inhibitors or ARB, is sometimes difficult due to the complications such as low blood pressure or kidney dysfunction. However, Ivabradine, a new therapeutic agent that selectively inhibits IF current in the sinus arterial node, can be safely used for CVR-CVT patients. And this is a very famous European Heart Journal 2022 guideline for CTRCD. And this is diagnosis of CTRCD, and it's categorized to two, which are symptomatic CTRCD, which is also a heart failure, and asymptomatic or non-symptomatic CTRCD. And for asymptomatic CTRCD, diagnosis is made with basically cardiac echo, which is the new LV ejection fraction reduction to lower than 40%. It's called severe CTRCD. And another criteria is GLS. If it's declined more than 15%, it's considered as moderate CTRCD. And even if LVEF is over 50%, if GLS is declined more than 15%, it's considered to be mild CTRCD. And this is also a very famous guideline of treatment published in Circulation in 2022, AHA guideline for the management of heart failure. And from step 1 to step 6, this is the flow chart of treatment for heart failure. And on the left side, you can see all the 4 key drugs, which is ARNI or ACE inhibitor or ARB, and beta blockers or MRA, and SGLT2 inhibitors. And if the medicine doesn't work, you may consider ICD or CTRD, and in the worst case, you may consider cardiac transplant. And consider additional therapies once GDMT optimized, and Ivabradine is here as a class 2A. And the other medicines are also written here, but Ivabradine is considered to be class 2A. And this is a research. 6 cancer patients were diagnosed with CVR-CVT by the ESC guideline. 5 patients had breast cancer, and 1 patient had colon cancer. All of them presented with HFrEF. Ivabradine was prescribed for these patients following the guideline of the Japanese Circulation Society. The outcome was compared by evaluating the symptoms, EF, and chest X-ray findings. Case 1 is 55-year-old female, and her chief complaint was systemic edema, dyspnea, and exertion. 5 years ago, patient was diagnosed with breast cancer stage T3N1M0. She started chemotherapy followed by surgery. After surgery, she continued chemotherapy. In spite of multiple chemotherapies, the cancer advanced over 5 years. She developed multiple bone metastases and multiple liver metastases and presented with systemic edema, and body weight increased by 10 kilograms. And this is her chest x-ray. As you can see, the heart is enlarged, and you can see the pulmonary congestion. Blood pressure was almost normal, slightly higher, and heart rate was fast as 112 beats per minute. And heart sound showed gout rhythm, and leg edema was bilateral, and BNP was elevated to 1747. And this is a cardiac echo, pastern four-chamber view, and ejection fraction was decreased to 37.2%. This is the apex four-chamber view, and as you can see, ejection fraction is decreased. This is short axis view, and also the wall motion is not good. And this is a chest x-ray before treatment and after treatment. As you can see, the cardiac shadow is much improved, and also pulmonary congestion was improved. This is a cardiac echo after treatment. As you can see, ejection fraction is much improved. This is short axis view. Oops, excuse me. Ejection fraction is so much improved. And this is EKG before treatment and after treatment. Ivabradine is working. A patient was stable for 6 months with Ivabradine 5 milligrams per day, carvedilol 5 milligrams per day, and spironolactone 50 milligrams per day. On monthly checkup, she presented with jaundice and liver failure. She developed hepatic encephalopathy and died. Symptoms of heart failure was controlled until she developed liver failure. Liver function must be monitored when Ivabradine is administered. Case 2, 72-year-old female. Chief complaint was dyspnea and exertion. 2 years ago, patient was diagnosed with breast cancer stage T2N1M1. She started chemotherapy with FEC, fluorouracil, epirubicin, and cyclophosphamide, then switched to nab-paclitaxel and HP. However, the cancer progressed, and she presented with multiple metastases in liver, lymph nodes, and bones. She was referred to cardiology due to declined LVEF, lower than 50% in echocardiography. This is before treatment and after treatment. And this is EKG before treatment and after treatment. Treatment started with beta blockers. Since her blood pressure was low, bisoprolol stayed minimal dose. Ivabradine 5 milligrams per day was added to bisoprolol. And CTR, chest X-ray, as I showed before, pulse rate, and BNP were all improved in 1 month. Patient was stable for 10 months. On monthly checkup, she presented with jaundice. The blood test revealed liver failure, and she died in 3 weeks. So this is CT scan. I'll just go run through it. And please note that her liver has a massive metastasis. It's all over the liver, all metastases. Case 3 is 40-year-old female. Her chief complaint was dyspnea and exertion and palpitation. 8 years ago, a patient was diagnosed with right breast cancer stage T3N1M0. She started chemotherapy with FEC and switched to docetaxel and then to paclitaxel, followed by surgery. 2 years ago, she had relapse on the left breast. She started chemotherapy with abemaciclib, but developed drug-induced pneumonia. After 1 month break, she started with paclitaxel and bevacizumab. She was referred to cardiology due to continuous dyspnea and palpitation. And she has implant in her breast, and you can see that the pulmonary congestion and pleural effusion. Patient had asthma when she was a child and recently developed interstitial pneumonia. Therefore, a beta blocker was carefully introduced at minimal dose. However, she developed asthma and bisoprolol was discontinued. She started with Ivabradine 5 milligrams per day. Her pulse rate decreased from 110 beats per minute to 90 beats per minute. Ivabradine was increased to 10 milligrams per day, and her pulse rate was decreased to 60 to 70 beats per minute, which is normal. She has been stable for 9 months without dyspnea nor palpitation. And this is before treatment and after treatment. EKG before treatment and after treatment. Case 4, 56-year-old male. 1 year ago, patient was diagnosed with colon cancer. He also had a severe renal dysfunction, so that he started hemodialysis before treatment of colon cancer. After surgery, he received chemotherapy with Folfox and bevacizumab. Over 6 months, he developed dyspnea on exertion and legs edema. Since his blood pressure was low, hemodialysis was sometimes difficult. He was prescribed with bisoprolol and ARNI, but the symptoms of heart failure progressed. This is a blood test result. As you can see, the kidney function is not good and HAMP is elevated. And this is the chest x-ray when he had a cardiogenic shock, and you can see the DC pads. And this is a cardiac echo for chamber view, and LVEF is decreased to 31%. This is apex for chamber view, and LVEF is decreased. Patient started with Ivabradine 5 milligrams per day. His pulse rate decreased from 90 beats per minute to 75 beats per minute. Ivabradine was increased to 10 milligrams per day, and his pulse rate was decreased to 50 to 60 beats per minute. He has been stable for 6 months without dyspnea nor edema. This is a summary of 6 cases. In cancer type, mostly breast cancer, and CTR is so much improved, as you can see, and heart rate is also much improved. Ivabradine is not regarded as a first choice for treatment of CTR-CD in guidelines. CTR-CD patients who cannot tolerate beta blockers due to low blood pressure are good indications for Ivabradine. In the literature, there are only 3 case reports that have used Ivabradine for CTR-CD. Conclusions. Ivabradine is suitable for the patients who cannot use standard therapy for heart failure. Ivabradine can be used even for advanced cancer patient who wants to continue chemotherapy. Ivabradine may serve as a key medicine in treating CVR-CVT. Thank you for your attention.